Hi, everyone. We're going to be talking about ultrasound guided interventions for carpal tunnel syndrome. Some very cutting edge research and different interventional injectates to help with the entrapment neuropathies that you commonly see when the median nerve is entrapped. My name is Yusuf Sayeed. I am the Director of Pain Medicine and Functional Rehabilitation for the Intrepid Spirit Center, Eglin Air Force Base. I'm an assistant professor at the University of the Uniformed Services and the Health Sciences in Bethesda, Maryland, in the United States. I don't have any disclosures. And just going back to this introductory slide, you can see the median nerve notated here by MN. In this particular slide, the disclosure slide, you can see those black arrows represent the transverse carpal ligament. Also with the white stars as well. You can see the median nerve is flush with the transverse carpal ligament, which is where you get your entrapment neuropathy. So carpal tunnel syndrome is the most focal entrapment neuropathy. Women are more predisposed to it than men in terms of prevalence. The pathology is due to various factors, including vibratory injury. You will see carpal tunnel syndrome in many laborers that are exposed to vibration, i.e., jackhammers. You will see it in military service members. Due to the shock from rifles or shoulder weapons. It can also be from mechanical compression, ischemia. So people with severe peripheral vascular disease that have peripheral extremity ischemia will develop carpal tunnel syndrome, and any type of demyelinating pathology. In this case, we'll be talking about the traction aspects of carpal tunnel syndrome as it relates to fibrosis or compression of the flexor digitorum, the flexor pollicis longus, and as they compress the median nerve, they form adhesions. And that type of fibrosis helps to diminish nerve glides. So just a quick review. The median nerve in this pictorial is highlighted in red, and that's where the entrapment neuropathy occurs as it travels underneath the transverse carpal ligament. And deep to that is the flexor digitorum profundus and superficialis, as well as the FPL, the flexor pollicis longus. The median nerve, it innervates the opponent's pollicis and basically the first 3.5 digits. So, in terms of the standard of care treatments, resting hand splints, modifying somebody's duty to reduce their exposure to whatever whatever movements cause carpal tunnel syndrome. You can put people into these splints or braces. You can inject them with steroid, and we're going to talk about some of those interventions shortly. And one of the more interesting interventions now are median nerve hydrodissection. And obviously you can ligate the transverse carpal ligament with various modalities, percutaneous ligation, open, and also ultrasound guided transverse carpal ligament dissection. And I won't be talking about that in today's seminar, but I have given talks on that previously. So a hydrodissection, it's fairly minimally invasive. You just need an ultrasound machine. You can use any type of injectate, including hyaluronic acid, normal saline, platelet-rich plasma, steroid, anesthetic like lidocaine, bupivacaine, or marcaine. And the idea is that it interrupts those adhesions that straddle the median nerve and cause it to be compressed against the transverse carpal ligament, and vice versa deep to it when the flexor tendons are activated, compressing the median nerve. And it allows for the median nerve to slide within the carpal tunnel a little bit more readily. So it decreases the risk of chronic constriction and improves the mobility. So in this video, you can see, from left to right, the needle tip is coming in just deep to the median nerve, and you're injecting. This is a form of hydrodissection of the median nerve, where you're just freeing the median nerve from the deep structures. So you would do this both deep to the median nerve, and then you would come back and do another hydrodissection superior to the median nerve to free it up above at the level of the transverse carpal ligament. And so this is a form of adhesiolysis in where that we are delivering, injecting not into the median nerve, because that would be very painful, but just outside of the perineurium. And this helps to separate the nerve from any potentially constrictive connective tissue. So when we talk about the biomechanics or how the median nerve travels through the tunnel, we want to understand how the simple hydrodissection affects those biomechanics. And so there was a study by Evers et al. Where they studied the biomechanics of hydrodissection. So they measured gliding resistance and energy for a control group and a group that had hydrodissection in 12 cadavers. And in fact, they used the technique that I described above. 6 of those specimens were treated with hydrodissection of 5 mils of normal saline, and 6 were the controls. Here you can see the baseline gliding resistance in millinewtons, and the baseline for hydrodissection group and the control group. And you can see the drop in the post-intervention group and the control group, which also had a statistically significant p-value. And then if you look at the energy, there's a reduced amount of energy for the median nerve to slide through, where the post-intervention group was 1.5 millijoules, the control group was 1.57, which also had a statistically significant decrease in energy, not between the groups, but from baseline to post-intervention. And you can see here, there was a statistically significant change in the force between the control groups at cycle 2 all the way through to cycle 100 until you reach neurolysis. And when you reach neurolysis, obviously, they both decreased because the nerve was ligated. So this is what it looks like after the intervention here. So in discussion, obviously this was a cadaveric study, and so many of the biomechanics are different between live human versus cadaver. The wrist was stabilized only in one plane, and we know the median nerve moves in different directions, and all of the cadavers did not have a history of carpal tunnel syndrome. So, well, what the study shows is that the kinematic properties show that there was a difference between the intervention and the control group, which is what we were looking for. And it was plausible that hydrodissection helps to mobilize the median nerve. So now let's talk about some of the mechanical and functional benefits. So there's all sorts of studies that have been published now where different types of injectates were used to treat both the distal and the proximal entrapment neuropathies. They have used PRP and dextrose, normal saline, hyaluronic acid, again, anesthetics and steroids. So going back to that slide, what we want to really look at is those randomized controlled trials. And one of those that Wu published et al. Had 34 participants, 17 of them were sham trials, 17 were with normal saline. And here you can see in that yellow box, what we're looking for is the symptoms and the functional scores. So the SSS and the FSS. Also, those are the non-surrogate markers, and some of the surrogate markers, including cross-sectional area, you can see between the intervention group and the control group. So again, at month 1, you can see month 1, month 2, month 3, the intervention group had a decrease in symptom severity scores, which is statistically significant in month 2 and 3, with still improvement even at month 6, but without a statistical significant level. And if you look at the p-values now, between month 1 and month 6, where you look at the mean differences, again, statistically significant decreases. And so you can see significant intergroup changes as well. When you talk about the sham versus normal saline, although the study was fairly underpowered, there wasn't enough patients to really call this a level 1 study. The cross-sectional area and symptom severity were decreased, but unfortunately it was inconclusive. And so let's look at some of the other injectates. So in this study by Wu again with PRP, it's a prospective randomized controlled trial with 60 patients. 30 of them were splintered with conservative care, and 30 went through PRP hydrodissection. And again, they used the Boston carpal tunnel questionnaire, cross-sectional area, and nerve conduction studies as their outcome measures. And so if you look at the p-value, also statistically significant differences in the Boston tunnel questionnaire, which is a scale of symptom and functional severity. And if you look at cross-sectional area, you can see those statistically significant changes as you relate it to the sham. So there was no change in the nerve conduction study, but PRP was superior in function and cross-sectional area. And the sham changes, we can rule out placebo effect because of this study. And we also know that carpal tunnel syndrome is not static. And so some cases will spontaneously improve. And so the baseline obviously showed no significant differences, but the post-intervention did. So this was a high quality study. So when we look at splinting versus PRP hydrodissection, obviously PRP was superior to splinting, and it may be more effective for mild and moderate CTS than splinting alone. If we look at steroids versus hyaluronic acid, we know that steroids have anti-inflammatory properties. Hyaluronic acid helps to improve the lysis of adhesions. This study was published in 2019. It was 40 patients, 20 in each treatment group. There was no control, but the measured outcomes were subjective pain, improved function, nerve conduction study, which is the gold standard of diagnosing carpal tunnel syndrome, cross-sectional area, as well as vascularity under power Doppler. And so if you look at the pre-injection, the symptom scale group, as well as the functional scale group, you can see statistically significant differences in the post-injection group, again at month 1, month 3, and also in terms of function and symptom scores in hyaluronic acid at 6 months as well. So symptoms decrease, the functional deficits decrease, which is our real marker in clinical medicine now, and the intergroup comparison was significant with hyaluronidase outperforming steroids. And this is what the sonographic data looked like in terms of cross-sectional area. You can see the cross-sectional area was statistically significant differences at 3 months versus the pre-injection. And so although that's a surrogate marker in terms that doesn't really relate to the clinical data as in symptoms, what we are looking for is a decrease in the cross-sectional area. So, and again, you can also see the nerve conduction groups had differences in both the conduction velocity and the latency. And so that's the box that's highlighted at 3 months. That's it did demonstrate improved signal conduction at 3 months as well. So in conclusion of that study, you can see that the hyaluronidase outperformed steroid. The limitation is there wasn't a control group to demonstrate efficacy between a sham group and these two interventions. But overall, hyaluronidase was superior to steroids. It had a improved Boston carpal tunnel questionnaire. The latency was improved, as well as the cross-sectional area. So the results were significant for at least 3 months. So in conclusion, there's been promising evidence in both safety and temporality of symptom abatement using hydrodissection. There's a paucity in the literature, though. We really need the gold standard injectate, whether it's hyaluronic acid or hyaluronidase, dextrose, PRP. Some people are using bone marrow aspirate as well. And we need to compare all of the injectates between each other with different patterns of dosing. So we need these larger multi-center trials. and we should always be looking for those functional outcomes and symptom severity. So if people go back to work or play or back to sport. These are my references. Thank you so much. I hope you enjoyed this conference.